the incentives are so bad, and they are completely the fault of the federal government. You're throwing the whole industry to the people who caused the whole problem.
If they're referring business to the system that they work for and they're rewarded and financially incented, they're getting bonused on that. Is that right?
People that go into medicine, by and large, are doing it for the right reasons. They want to help people. And then they find themselves in a situation where they're being coached and told and coerced into things like referring to surgeons in a hospital system who they know are no good.
Are you sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Kober. I am your host, and today I am delighted and honored to have with us Dr. Keith Smith from Surgery Center, Oklahoma, and also one of the founders of the Free Market Association. It is a pleasure to have you with us, Dr. Smith. Welcome to Broken Healthcare.
Thanks for having me. This should be fun.
Yeah, we aim to please. Insurance and medical talk can get a little stale and dry, but I aim to entertain my audience, and I don't think you're going to disappoint, Dr. Keith. And can I call you Dr. Keith? I think that's kind of what you go by.
Sure. Yeah. Call me whatever you like.
Excellent. Well, why don't we start with your journey to the medical profession? When did you know you wanted to become a doctor?
I think it entered my mind when my brother actually went to medical school, and it really was not on my mind before then. We had a great uncle who was a hero physician in a small town in Oklahoma, and we were aware of Dr. Bay's story. But, my brother decided to go to medical school, and I was actually more on track to be a musician. And so I had a double track. And
tell. What did you play? What do you play?
Well, I was a pianist, and I had a good shot at doing that for a living as a concert artist. So in college, I had kind of a double life. I was that musician, a classically trained pianist, and also, heavy into the sciences that were all medical school prerequisites. So I think that, having grown up in a home that was a Christian home where, the golden rule and treating people like you want to be treated, mutually beneficial exchange, that was in my DNA. I was hardwired. And I knew that as an entertainer, that would be a mutually beneficial exchange with an audience. But as a physician, it is that on a much deeper level. And I had the fortune of meeting some physicians who turned out to be mentors, who actually sang in the church choir where I was the organist while I was in high school.
Huh.
And they took me under their wing, and I was hooked. So I just realized, if you want to make an honest living, if you want to help people, and be rewarded for that in a reasonable way, and have grateful clients to whom you can provide a great service, that was all hardwired in me. So I think I was made for it.
Huh. And so were your motivations at all, did you think about, hey, can I make money as a musician versus, making a living as a medical doctor? Did that come into your, analysis at all? Or was it really kind of mission driven, and at your core, you just decided, hey, this is the path for me?
Yeah, I could make money as a musician. Anybody that goes into medicine thinking they're going to get rich is an idiot. So, yeah, I mean, I
Yeah.
had an opportunity also to be a studio artist in a couple of big cities and big studios where I really could have made a lot of money, but I just decided that it was not going to be as meaningful to do that. It wasn't going to be as gratifying for
Mm.
me long term. So uh, that's really what made the decision. The physicians I knew made a good living.
Mm.
I wouldn't say they were rich.
Yeah.
So I had an idea just from the physicians I knew how what sort of lifestyle was a possibility.
There are folks that get into medicine, though. I'm not saying they get into it for the money, but they're highly compensated, right? If I think about cosmetic surgeons, or I think about fertility, surgeons, doctors. Some of those, some of those physicians are doing very, very well
Oh yeah,
into the seven figures. So it's and beyond, I would imagine. But in your calculus, in your analysis, it was not a money grab. It wasn't, hey, I'm gonna go pay my dues at medical school, residency, et cetera, for the money. It was really more mission driven.
yeah, yeah. I knew I would be comfortable as a physician, and I'd be comfortable as a musician.
Right,
So
right.
that had really no bearing.
So if I came over to your place and I rated your music collection, what would I find?
Oh, mostly classical and jazz. I'm not a snob though. I have a talent fetish. I mean, somebody can play really garbage music, and if they're a really talented musician, that gets my attention. So I think I'm more dialed in on whether someone is talented.
Okay.
Yeah,
So what do you think of John Paul Jones, Led Zeppelin?
great stuff.
Yeah, you're a fan.
Oh yeah, no, Led Zeppelin, greatest rock and roll band ever.
Oh, right on. All right, good. So we could continue the conversation. Only kidding. I'm actually going to see a concert tomorrow in New York City at the Beacon Theater, Tedeschi Trucks Band. I don't know if you're familiar with them, but
No,
yeah, kind of. I would describe them as rhythm, blues, fusion, funk. Um, it's kind of an ensemble band, so they're like 10, 12 piece, two drummers. It's pretty good stuff. Anyway,
cool.
but I digress. So getting back to medicine. I know that I believe your path started in a traditional healthcare system. And what was your experience like, and where did your path go from there?
Yeah, so I was trained, did my anesthesia training in Little Rock, Arkansas. Stumbled into a situation I did not anticipate that the children's hospital there was almost completely endowed by the Walton family, and it was really an astonishing training experience that I had. So I left that training with pediatric and cardiac specialty training and came back to Oklahoma City, where basically I'm from, mainly to do cardiac anesthesia and some pediatrics. I wound up doing more pediatrics than cardiac just because of the demand.
Hmm.
Um, but I was in traditional hospital practice for 7 years, filing insurance claims, part of the problem,
Uh,
and I realized I was part of the problem in about 1992, late 1992, that I was essentially an accessory to a crime.
hmm.
That hospitals were financially assassinating patients that I was giving an anesthetic for and for very minor procedures, the supplies for which I knew were not that expensive.
Hmm.
So Medicare decided to slash physician fees drastically in the early 90s, and the insurance carriers followed suit. So physicians, as a rule, in the early 1990s saw their incomes fall dramatically, while at the same time, the hospitals where we worked were growing at a record pace, adding on to their um, administration staff, adding on to their buildings, buying out competitors, sponsoring sports franchises. I mean, they were doing so well.
Mm.
And the patients were really disenfranchised. They were left in the cold and left to pay these huge balance bills given to them. So I did that for 7 years, and that was not okay. It was not a mutually beneficial exchange. I was part of the problem. And so I walked away. I left that practice, and another like-minded anesthesiologist and I launched Surgery Center of Oklahoma in May of 1997.
Great. So I want to dive into that, but if back up, if you will, for me, because I don't think the average person, and I certainly don't have a grasp on what a day in a life of an anesthesiologist is in a routine environment in a traditional healthcare system. And you managed, you mentioned paperwork, what was involved. Now, do you have staff to assist you with this? Is that taking up a big chunk of your time, day in and day out? And also, these are multiple questions, but in terms of that change in Medicare and them lowering the reimbursement for physicians and anesthesiologists, where did that decision come from? It's hard for me to wrap my head around why all of a sudden an insurance carrier deserves more than a practicing physician.
Yeah, so the history of Medicare is long forgotten. Most people are not aware. When it came into being, 70% of people 65 and older had indemnity insurance. So they were not without insurance coverage. The only way Medicare, the government, could get physicians on board with the Medicare program was to agree to pay them whatever they charged. So there still were some renegade physicians who refused to participate in the Medicare Ponzi scheme, essentially, and they never did file claims.
And time period for reference,
It's
what
about
time period are you talking
This
about?
is late 1950s, early 1960s.
Okay.
So the government largely socialized the hospitals in the United States in the late 1950s, something called the Hill-Burton Act. And that's where all the money for the community hospitals that sprouted up came from. It was just logical that they would then try to socialize physician payments as well.
Mm.
And that's what they did with Medicare. And they got everybody essentially on board by agreeing to pay whatever they charged. Well, you can imagine what happened to whatever they charged. It went through the roof.
Right.
And that's the beginning. The government gets involved and screws everything up. And that was the beginning of soaring costs in the United States. Well, it was not anything that was sustainable. So, in order to cut back on Medicare's expense and in order to basically ration care to the elderly in early 1990s, Elder George Bush signed the resource-based relative value scale into law. And this was an effort where some idiot economists from Harvard decided that they could apply.
Tell us how you really feel, doctor.
No, well, it's just true. I mean, it's basic economics. They thought they could apply a
Yeah.
price to every service that a physician offered, and they got them all wrong.
Mm.
I mean, true pricing emerges from competitive activity in a marketplace.
Free market.
It is. And they imposed pricing on every service that physicians could offer, and they got them all wrong. So they got a bunch too low, they got a bunch too low, and they got a bunch too high.
Mm.
The ones that were too high caused a huge surge in those services being offered. They caused a surplus,
Mm.
and those services which were too low resulted in shortages. So, just to give you an idea, um, you're asking about my day. I get up early in the morning and do an anesthesia, provide anesthesia for a patient having an open heart surgery that would last 6 hours. On and off the pump, and the bypass machine. Fairly difficult case, and Medicare would pay me about $290.
Oh my God.
And so you can't make a living doing that, and so ultimately hospitals had to that were making a lot of money had to subsidize the anesthesia care because RBRVS was just so wrong. But it caused a shortage of cardiac anesthesia in the United States, and
Mm.
hospitals had to subsidize that care. The last knee replacement on a Medicare beneficiary for which I provided an anesthetic paid me $78. So it was just easier for me to provide that care charitably. And that's what I did. Philosophically, I'd also come to a place where I'd realized the government has no money that they did not first confiscate from some hardworking individual. So for me to file a Medicare claim and receive that money made me the recipient of stolen property.
Mm.
And so I just quit filing claims and I provided care to Medicare beneficiaries free. And that caused a little bit of a stir, but that's what I did. And if anybody else decided to do it, that was fine. If nobody else did, that was fine too.
Mm.
But anyhow, that's kind of where I was, and I saw the hospitals just getting rich.
No, but Dr. Keith, unless I missed something, how do you provide it for free? It's a charitable write-off, or
No, you don't even file a claim. You
you don't
just show up, perform the service, and don't bill anybody and don't file a claim. That's what I did.
and then how do you pay your bills?
Well, I had other anesthesia.
Non-Medicare. Okay.
Yeah,
Yeah.
yeah. But when the Medicare patients came in, I just didn't file a claim.
Wow. That's remarkable.
It just didn't seem right. I didn't want to legitimize what I increasingly saw as an illegitimate system. And everybody that's honest knows now, Social Security, Medicare, they're Ponzi schemes where current current workers are essentially paying the bills that the elderly incur.
Mm.
All the money that everyone has put into Social Security and Medicare is long gone.
Mm.
That's all gone. So anytime someone files a claim with Medicare, that's swiping the credit card of someone's grandchild because that
Yeah.
money's all gone. Those programs are completely bankrupt.
Unbelievable. It's you're speaking the truth. I know. It's a mind blower to me that some of this stuff just seemingly happens randomly. Some economist at Harvard makes a decision randomly and gets it wrong, and everybody pays the price for that decision. And it's a trickle down effect that really kind of takes on a life of its own, right? Because now we have stuff that you would never dream of, I don't think, 50, 60 years ago in medicine, with charge masters having
Right.
300 different rates for the same procedure.
Right.
And
And
it's
that's
just,
all. That's all the result of RBRVS. And I've had to caution myself to not necessarily grant them the grace and the gift of ignorance and stupidity. You know, some of this you could argue was very strategic.
architected. Yeah.
Yeah, and so I don't know if they're diabolical or they're dumb, but I think just saying they made a mistake, they were dumb. That's gracious. That's charitable. I
Yeah.
think that's a charitable way to look at it.
Yeah, it's kind of infuriating. So we were at a conference. I didn't have an opportunity to meet you at the conference, by the way. I saw you on stage at Rosetta Fest in D.C. And Dr. Marty McCary just released his new book, and I'm about halfway through it at this point. And it's infuriating that in the medical profession there are studies that are given credibility. They're published in medical journals, JAMA, et cetera. And there doesn't seem to be, and I don't know what your thoughts are, but as a layman who's reading through the text and not only what's in Dr. McCarry's book, Blind Spots is the name of the book, by the way, folks. If you have an opportunity, go out on Amazon, get it, read it. It's mind blowing, and some of the stuff that he shines the light on, though, I'm just amazed that it got as far as it did, to the point that now it is the norm. Physicians are adopting this in their practices, and he's talking about things like not including peanuts in the diets of children ages 3 and under, because of out of fear that it might spike an allergy, reaction that could result in death. And now apparently that is no longer accepted as truth, and pediatricians are back to introducing peanuts into the diet at a much earlier age, mixing it in. And his epiphany came from talking to some of his interns who were from Africa, who said, "We don't have this in Africa."
Right.
Like, it doesn't exist. And so, but the dogma exists, and physicians accepting this based on a study that really is statistically not accurate is a mind blower to me, and it's infuriating. And so I'm trying to tie that together with what you're talking about with Medicare and the payment system. And it just seems to me that this stuff doesn't happen by accident. I believe that, and I where I was going with it, I just kind of reclaimed my thought. There was a post on LinkedIn that I responded to, and it's just like, the answer is money. What's the question? There's right. It doesn't seem to be accidental. It doesn't seem to be. We can't be that stupid, right? If medical professionals and scientists stick to the science, and they look at a statistical analysis that clearly by the numbers is invalid, how the hell do you publish that? It just doesn't make sense.
Well, in part of Marty's book, I'm honored to call him a friend. Part of Marty's book, though, outlines the consequences for any physician or individual that decides to buck the mainstream. And I've got scars on me for things that I've done, and what I think I realized early on was that I needed to stop fighting the system. I needed to walk away from the system. I, you cannot do business in an honest way with criminals, whether they are part of the cartel of Uncle Sam, the insurance carriers, and the big hospital systems. It doesn't matter. You can't do business with criminals, and claim an honest day's work.
Yeah.
So I think the reason that it has gotten it's this way is that the consequences to fight the mainstream are severe. My solution, after I realized I needed to stop flailing away and fighting the system, was to secede, was to walk away and begin to create something different, a parallel medical services economy. And I feel so vindicated because I'm seeing it now. And I think a lot of efforts like this don't materialize during the lifetime of someone who's lit the fuse. But it's very cool. It's very cool. It's great news. This is a good news story. And there are not a lot of good news stories out there, particularly in medical services. But this is something the American people can really get excited about. The innovation that is happening, the price transparency, that is now being demanded by the industry. People are asking the questions that they should ask because you're right. The answer is money, but they're asking the questions. Why is a tonsillectomy 1/10 at the Surgery Center of Oklahoma what it costs at the so-called not-for-profit hospital down the street?
Mm.
They're asking those questions, and it's very, very healthy.
And is it medically necessary to begin with?
Well, yeah, I mean, there is that too. That's a whole different topic.
Yeah,
Uh, but that is all downstream of RVRVS
right.
because downstream of that came the relative value units, RVUs. And if physicians don't, put up their RVUs on the scoreboard, then the hospital that employs them has a reason to cut their pay. So the incentives are so bad, and they are completely the fault. If you want to get to the source of it, of the federal government, and I think that's important for people to hear as they think, Medicare for all sounds good. You're essentially throwing the whole industry to the people who caused the whole problem. They're the source of all that's wrong.
So when you discuss RVUs, relative value units, how focused is a practicing physician in a healthcare system on RVUs, and is it motivation for them to refer care within the system that they work in?
Oh yeah. So the viewers should know that half or more of the physicians in the United States are employed by hospitals. That means they work for the hospital, they don't work for the patient.
Mm.
The other half are not employed, and so they have every opportunity to work for the patient in a completely unconflicted way. The physicians who are employees are completely focused on RVUs and their production as measured by this system called relative value units, because their pay and their bonuses are based on that. Some of the primary care doctors have figured out, the ones who are employed by hospitals, that they can actually throw more RVUs up on the scoreboard by referring for tests and specialty care than they can by actually seeing patients. That's why the waiting room of a primary care doctor that's employed by a hospital system could be empty, but that practice is generating large amounts of revenue for that hospital system. So, you can have a physician who is not seeing very many patients, but there's a waiting line to see them. It's because they could see one patient, order a bunch of tests and referrals, and throw those RVUs up on the scoreboard, and that's all their employer really cares about.
Yeah, so they're generating money for the healthcare system that they work in,
That's
and
right.
and they're
That they work for.
for for
Yeah,
yeah.
they work for them.
Yeah, thank you for correcting me because that's
Yeah,
exactly right. They work for, and simultaneously, in my mind, I'm almost like, hey, they're commission-based salespeople, right? They're
that's right.
if they're referring business to the system that they work for, and they're rewarded financially incented to refer that MRI, that CAT scan, that diagnostic exam, those blood works to the system that they work for, they're getting bonused on that. Is that right?
Yeah, and that's where a lot of this moral injury comes from because, people that go into medicine by and large are doing it for the right reasons. They want to help people.
Yeah.
And then they find themselves in a situation where, they're being coached and told and coerced into things like referring to surgeons in a hospital system who they know are no good, ordering tests that are probably unnecessary, but they're doing it really in self defense. And
Mm.
so, and there are some really brave physicians that are employed that are fighting this every single day. but eventually they get beat down, and they either walk away and practice independently, or they succumb, and they do what they're told, or they just quit. And so there's a lot of it's moral injury and burnout, and a lot of it I think is because a physician knows that the best gallbladder surgeon in the whole region practices across town, and they can't refer to them. They have to refer to the butcher down the hall. And that's the kind of stuff, when you see those people in follow up, who've had a bad outcome, that's the kind of stuff that really wears on anyone with a conscience. And I would argue the vast majority, almost without exception, people who go into medicine, that's really bothersome to them.
Does that really happen, doctor? I mean, I'm sitting here with my jaw's kind of dropping. It's like
Every day,
physicians are
every,
recommending, folks, hear what
oh,
he just said. They're recommending the butcher down the hall
every
versus
day,
the excellent doctor that's across town
every day.
because their hands are tied. They
Oh,
have to do it.
every day. That's the advice I give medical students, is never go to work for a hospital, because that dilemma is inevitable. And no physician should ever find themselves in the place where they have to decide, do I do what's best for this patient, or do I do what I need to do to preserve my relationship with my employer? I mean, whose bread I eat, his song I sing, is a great proverb that's true.
Mm.
But it is it's torturous. And that people say physicians shouldn't own hospitals. I say, well, if physicians can't own hospitals, why can hospitals own physicians? I mean, if one's a conflict of interest, why isn't the other? And that is a deadly uh, distortion in the marketplace, caused once again by the federal government, because Medicare overpays for primary care services and physician services if that physician is employed by a hospital. So that that the subsidy is there to facilitate the hospital employment of physicians. And once again, it's just an incredibly distorting gift and favor that's been auctioned off in DC to these big hospital systems. And then the hospital systems want to employ primary care doctors to guarantee that they receive the referrals. Because the last thing they want to do is compete in an open marketplace on quality or price.
Sure.
That is the opposite of what they want to happen.
Well, and
So,
that's why I
yeah,
believe we're seeing this trend of hospital systems acquiring and gobbling up all of these
yes,
private practices.
yeah, and their prices always go up when consolidation occurs. That's not the natural order of things. My friend Jim Epstein at Reason Magazine, when I ask him, how do you decide what's a juicy hot story? He says, I look for business consolidation, because that's not the natural order of things. In a competitive market economy, you tend to have more competitors show up.
Mm.
So whenever you see consolidation, the dirty hand of regulators or legislators or government and insiders, that dirty hand behind the curtain is at work.
Yeah. I think what makes it even more difficult is the fact that folks tend to have this affinity towards a hospital that, you know, does great advertising and is their local hospital. And of course, and people kind of, you know, say it as a badge of honor. I had my surgery at NYU. I had my surgery at, you know, Cornell. I had my surgery at Columbia Presbyterian.
Right.
And the reality is, it's kind of like a box of chocolates. You never know what you're going to get.
You
And,
don't.
and until you drill down and, you know, you're looking at the quality scores for physicians, surgeons within those healthcare systems. But it sounds to me like in most cases you would avoid the quote unquote big hospital system wherever possible. Are there situations where you don't have a choice? There's, you know, something going on that really a freestanding clinic such as Surgery Center of Oklahoma, which we're going to get to in a minute, just doesn't have the capacity, the ability to deal with what?
Yeah, and you're right. You're right. There are things that need to be done at a major medical center. There are a lot of things, obviously, at an outpatient surgery center we cannot do. There's a
Mm,
lot we can. Um, when it comes to quality, there's some great doctors in these big medical centers. There's no doubt about it. Marty McCary's first book, most people haven't read, is about healthcare quality. It's called Unaccountable.
mm,
And Marty's a scientist. He's a legitimate scientist. And at the end of the book, he throws up his hands
yeah.
on how do you determine if a hip replacement at a big name medical center is any good. And his conclusion was you should do a survey of the staff who work there and ask them, would you have Dr. X do procedure Y in this facility?
Hmm.
And surveying the staff turned out to be the most reliable way to figure out whether you ought to have your knee replaced there, you ought to have your tonsillectomy there. So the quality scores, they're very flawed because they're self-reported. And the other thing you have to keep in mind is in the hospitals, the people who bill these coders, they upcode everything. So these Medicare quality, this data that comes from Medicare for quality scores is all flawed because what has actually been done bears little resemblance to what was coded for and billed because of the upcoding process. So I think we have to be really careful with the data. There are people I think that have a real data fetish, and I think they ought to read Marty's book Unaccountable.
Mm,
Uh, but yes, there are procedures that cannot be performed at an outpatient surgery center. Fewer and fewer, though.
mm.
When I started my career, there really were not any joint replacements going on in outpatient surgery center. Cochlear implants didn't exist, but when people started doing cochlear implants, that was an inpatient surgery. There's so much now that can be done appropriately in an outpatient environment or with an overnight stay.
Hmm.
And we do all those things I just listed. So um, every year that goes by, every 5 years that goes by, there's some new innovation in surgical technique or pain management from the anesthesia staff that allows an even greater amount, a greater percentage of procedures to be performed on an outpatient basis. There's certainly procedures that must be performed on an inpatient basis. We need hospitals. We just don't need them to bankrupt us like they're doing.
No question. So take us back. We kind of raced ahead, but take us back to the moment where the rubber met the road. You told us, you were paid next to nothing for being on your feet for 6 hours, doing what you do. And you had that, that straw that breaks the camel's back moment. But that also had to be, pardon my language, an oh shit moment for you, because you're breaking away from kind of, the entity that is providing a salary so that you can provide for your family, and you're breaking away and you're going rogue, you're going renegade. So what was that moment like for you psychologically? Was it an easy decision? Did you struggle with it? Where were you emotionally?
Oh my gosh, it was wrenching. It was so hard because keep in mind, I was making a great living.
Yeah.
Over time, my exposure to Medicare patients dropped drastically because I eventually stopped doing cardiac anesthesia. So I think what happened was, like in Ghostbusters, where the streams crossed. At that moment, my anesthesia group was very unhappy with me, and they began to entertain these socialistic income sharing ideas that I could not abide. And a surgery center that I was familiar with was financially failing. and it seemed like an opportunity. So another anesthesiologist and I basically bought the operations of a failing surgery center on a hunting trip,
Mm.
and that opportunity coincided with um, the just vicious dispute within our anesthesia partnership about fairness. And I had to get out of there, and my partner Steve Lantier, he had to get out of there too. We're completely like minded, so we
Yeah.
walked out, and we walked away from our very successful anesthesia practices, and that was our moment.
I love that. Those are defining human moments. They're defining. I think everyone has that in their life, regardless of your profession or what you do. I believe that there are forks in the road that we get to, and your decision to go right or left makes you who you are. And so I really admire the you chose the road that looked like fire and brimstone. As opposed
Yeah.
to the one that is sunny and beautiful. Like life still would have been good had you stayed where you were, but you made a decision to go left instead of right. And what was your when you first started out? What types of procedures were you doing?
Well, when we first started, we had a we had a mission statement. Our mission statement was, we will provide the highest quality care possible. We will not work with surgeons who we would not let operate on us. I'm talking as an anesthesiologist. Steve Lantier and I made these decisions.
Right.
And we will always let patients know what they owe us before they arrive. There will be no bait and switch surprises after surgery.
Mm.
And we'll never take a dime of money from the criminal syndicate of the federal government. We just will never ever deal with them. And
Wow.
so that was our mission, and that helped define who we were going to work with and what kind of procedures that we did. Because the facility that we bought already had certain types of equipment, it made sense to work with orthopedists, general surgeons, and podiatrists. And then with our pediatric training, we also worked with the ear, nose, and throat doctor and two pediatric ophthalmologists.
Mm.
So we started with about 12 surgeons, and it's now about 130. So the organization has grown. We didn't buy the surgery center; we just bought the operations. We inherited the lease, and so our capital expense early on was just Steve Lantier and I signing everything we owned and could possibly earn in the future on a document.
Oh, love
Um,
that.
yeah, that's how we did it. I mean, we
Yeah.
went we went double down, all in,
You burned the
and
boats.
we did. We burned the ships. That's exactly what we did. Burn the ships was actually the theme of the Free Market Medical Association about 3 years ago.
Oh, that's hilarious.
Yeah, we were encouraging everybody like Cortez, burn the ships. So
See, I'm channeling the universe here, folks.
yeah, so we were there. Steve and I anesthetized the children of the self-funded company owners, the
No,
who's who.
but wait, how does it happen? Like, all right, so you make this decision, you buy the operation, you just start having conversations with surgeons like one at a time, doing outreach, like, hey, we're building it, we want you to come.
No, it was already open. This
Okay.
is a facility that was licensed and open but failing.
So
And
they
when
they
Steve, yeah, yeah,
they
but
they
when
had they had a calendar that was booked with surgeons that
no,
oh, they didn't.
no, no,
Okay.
it was just a facility
Okay.
with lights and operating rooms, and we walked in, brought our own staff, and when we walked out, there were surgeons who went with us,
Mm.
and they did that because just frankly, the quality of anesthesia that Steve Lantier and I offered to the surgeons was great, and that's why they left. They left with us, and they also saw, the possibility of a real business opportunity.
Mm.
But yeah, we had these surgeons came with us. We walked out, and they walked out with us. They came
Wow.
with us. Now they continued to work at the hospitals, but they, when they had a patient that needed a procedure, the performance of which was appropriate at our facility, they would bring them there, and we outgrew it. I mean, we did all the Division I athletes in the state of Oklahoma, except for University of Tulsa. We did that. We just had a great quality reputation, and we were reasonably priced. And the insurance carriers hated us.
I
We
wonder
couldn't.
why.
Well, we couldn't figure it out because, in my mind, cheaper and better. Why wouldn't an insurance carrier want that? But I didn't
Sure.
understand the
You-
way the money flows and how they do better when the initial bill is really high and they skim off the discounts. I didn't understand all that repricing garbage.
And
at,
for the
at the
sake
time.
for the benefit of our audience, who may be lay people that are just tuning in to try to get a handle on what's going on with healthcare, what Dr. Keith says is exactly right. Insurance carriers, particularly in today's day and age of the Affordable Care Act, with the medical loss ratio that's baked into it, they don't. It's not as if they pay less for a procedure that's done at Surgery Center of Oklahoma, they're capturing the difference and they make more money. That's not how it works at all. You might think that, like, logically, but the reality is they are only able to capture a percentage of the overall bill charges, and it's 15 to 20%. So they're not incented to have bills be lower, because a lower bill means less that they can keep back for administrative overhead and profit. So it's counterintuitive, folks, but they want the bills to be high.
Yeah, I actually made a YouTube video. It's called the $100 aspirin that walks through that, because a hospital will bill $100 for an aspirin and only get paid $5, but they'll claim they lost $95, and that way they have the red ink needed to justify the fiction of their not-for-profit status. But no one pays $5 for an aspirin, but they'll claim they lost $95.
Oh,
But then
God.
the insurance company, the carrier, particularly if it's a self-funded plan, will claim a commission on that savings achieved. So, they will say, we saved you $95 because we discounted this aspirin from 100 down to 5. We saved you $95. You owe us, 28% of that. And so if I say a tonsillectomy is $3,050, all in, surgeon, anesthesia, facility, pathology, everything, that's an opportunity foregone for a price skimmer. They really need me to charge 30,000 for that, so they can skim off their fake discount. And that's why they hate us. They've always hated us. They still hate us. We don't have an insurance contract at Surgery Center of Oklahoma, and except for a very brief time with Blue Cross, which was a horrible mistake on our part. I'm embarrassed to even admit. Except for that brief time, we've never had a carrier contract.
And it didn't go so well, I would imagine.
No, it was horrible. It was just awful.
So, at a very basic level, if I am, remodeling my home and I want to put a kitchen in, I believe I have the opportunity to shop and talk to several general contractors and ask them what their estimate is for the job. And I think I have a right to ask them to break down the materials and the labor so that I understand exactly what I'm getting for my dollar. The same thing isn't true in healthcare, though. You don't have the opportunity, generally speaking, to shop and know in advance what the cost is. And I think that's a big part of what you set out to do at Surgery Center of Oklahoma. And I know that it was an evolution, right? You you said you started in 1992, I guess, and
97.
oh,
Correct.
97,
Yeah.
97. Okay, so you started in 97, and obviously you were focused on building a business and a practice with the core values that you and your partner set out. Hey, this is our baseline. We're not going to deviate. At what point did you start publishing prices and think that that was a good idea?
So when we opened in 1997, within a couple of weeks, I was quoting all inclusive surgical prices over the phone to
Hmm.
patients who were asking how much, with no concept of how radical that was. And inguinal hernia, tonsillectomy, breast biopsy, I mean, you name it. So we had this list of prices that I had quoted over the phone for years. We outgrew our facility, built the facility that we're now in 2003. And in 2009, I decided to post all of those all inclusive prices on a website due to a very successful attack by the insurance companies and hospitals in Oklahoma that ended up stacking deductibles on us. So patients, we were filing out of network claims, but the insurance commissioner allowed the carriers to deny any out of network benefit unless an in network deductible had been met.
Hmm.
And that just about closed us down.
Oh
So
my God.
so I posted all of our prices online in 2009 with three goals. One was so buyers with sticker shock, individuals, high deductible, self funded companies, cost sharing ministries, so that they could better find us as an affordable option.
Hmm.
My second goal was to start a price war because I wanted the place charging $30,000 down the street, claiming to not make a profit, to have to answer some hard questions when the buyer, yeah, when the buyer could see that that could be purchased all in at my place for a tenth of that. The third goal I had was to better understand some of the scams that I knew had to be at play because this is America, for God's sake. If you're cheaper and better, you ought to be busy. But the cartel and the way it works is just such a web, and it's so messed up. This like price repricing of claims and
Hmm.
skimming off discounts. I mean, who knew? I didn't know at that time. So I wanted to better understand what was going on. So I launched this website in 2009, once again, with I think I knew how radical it was at that time, and I knew what I thought I knew what I was in for. It was very disruptive. And the first patients that took advantage of our online pricing were Canadians. So, they're
Really?
yeah, I mean, they're standing in a line, that's 2 or 3 or 4 or 5 years long, waiting on a very reasonably priced procedure that will change their life.
Hmm.
Women that were getting transfusions because they were waiting in line for a hysterectomy they needed so badly for their bleeding. And for $8,000, they could end their nightmare and get back home, and we could schedule them the week they called.
Hmm.
So yeah, I
Wow.
mean, we launched this website, and I would argue it has really changed things in the entire industry. It's been very vindicating for me to see.
It's amazing, and it's just common sense, isn't it? You're being transparent, and I believe everyone deserves transparency in healthcare. It really has gotten so convoluted, and there's really only one reason for it, and it's greed, and it's bad. It's a wonder that, and I guess this is a question: why hasn't your model taken off? And why don't I see more freestanding surgical clinics popping up everywhere to compete with all of this corporate greed? Let's call it what it is. And even if you're a nonprofit that's flying under the umbrella of a religious institution, you're I'm sorry, but you're part of the problem.
They are. Well, the answer to your question, it's astonishing that a free market movement exists at all.
Hmm.
It's astonishing that the Surgery Center of Oklahoma is open at all. Uh, that we opened in the beginning and that we have managed to stay open.
Mm,
The headwinds are indescribable.
yeah.
Uh, I could fill a book with the headwinds, with the amount of time I spent uh, battling in self defense at the state capitol here in Oklahoma City just to be left alone. The headwinds are incredible.
Yeah.
So it's astonishing that there's any kind of transparency or free market movement at all.
Well, let me
That,
interrupt you there, doctor. I'm
but it is,
sorry.
but
I'm
it
sorry,
is
but
growing.
what really disturbs me is the fact that you are up against this challenge and that you have to contend with your local and state government, and that your Department of Insurance is seemingly not in support of this. And I'll go a step further, and I will say that I believe, and this is was kind of part of my rant in my reply to Dr. Marty's book, but I believe we prosecute and incarcerate people for BS every day in this country, but we don't go after politicians. We don't go after the people that betray the public trust for going after and vilifying folks like you, and that has to change. We need to set an example in this country of not rewarding bad behavior, but making an example out of bad behavior. Because, folks, in my humble opinion, they're selling us down the river. There should be nothing wrong with doing what Dr. Keith Smith and his partners are doing at Surgery Center of Oklahoma. For him to be up against it and fighting for survival it's testament to the machine that is going to shortly be a $5 trillion machine, 20 cents in the dollar, that I am sure is operating against you and making your life miserable in every way that they can. But we need to shine a light on, if folks are coming after you and they are the State Department of Insurance, if they're political at all and they're against you, man, we need to mount a PR campaign and we need to shine a light on why are they against you, because that's the only, I don't see how else to get ahead of this. What is their motivation? How could they possibly be against what you are championing? I don't get it.
Well, and I think I was on that page with you years ago. I was fighting, and I realized it was futile.
Mm,
That if I am truly a believer in the power, in the beauty of the free market, as Murray Rothbard described it, and those ideas are correct ones that undergird really the American concept of mutually beneficial exchange, then that's where I need to put my focus. So I am here now vindicated because the same hospitals that tried so desperately to put me out of business for years are now participating in this movement. They are now matching my pricing so they don't lose business.
hmm.
I am now referring to them business that I cannot appropriately perform in the outpatient setting, and we are working together.
Hmm.
So I have come full circle to a place where I think that it's time for everyone really to come to grips with and adopt this market economy and not bankrupt patients and honestly say, here is what I do and here is what I charge for it. And I think we're very close to a time where we actually will need to extend grace to the worst of the price gougers, and instead of beating them down beat them down with competition, beat them down with the market and market competition. The people who prevent this movement from growing are the legislators, and the legislators sell these favors to the industry at an auction, and most of it happens in D.C. and it happens in local and state government as well. But the author John Barry said, when you add politics and medicine, you get politics, and that's exactly what's happened. And my approach has been to walk away. And is this basically criminal? Yeah, it is. But this is such a great news story that surgical services and direct primary care, oh my gosh, there's a whole episode for you. These are really good news stories where affordable, high quality care is available to the American people. And think about it. When I posted prices in 2009, I had a tinfoil hat on my head. Now we have an executive order signed by one president, backed up by another, that makes what I did the law of the land. So we've done a 180, and I think what the American people need to do is not seek out people to flog. What they need to do as buyers is demand price transparency, and do it in a very aggressive way, the way an American shopper typically does. The argument that some medical services you can't shop for. If you're injured in an ambulance, who is shopping then? I don't buy that. When I met with John Stossel right before our first interview together, he made a very insightful point that businesses who act in an unethical way have reputational damage that follows them. And so hospitals that financially brutalize patients who are unable really to defend themselves should, in a market economy, have reputational damage that would follow them. Likewise, a hospital that treats someone who is extremely vulnerable in a very kind, healthy way should have their reputation bolstered as a result. So, not everything is happening in real time in this market economy when it comes to the consequences. But I think this movement is growing. I mean, the Free Market Medical Association that I co-founded with my friend Jay Kempton it now has 37 state chapters.
Wow.
So this movement, that it exists at all, is very surprising. That it is growing is
I'm glad you
astonishing.
mentioned that. Tell us a little bit about
Astonishing.
that.
Yeah, so the Free Market Medical Association is a gathering of people in the industry, buyers and sellers. So running Surgery Center of Oklahoma, I would be a seller of medical services. The buyers are either individuals, cost sharing ministries, or self funded plans. Marty McCary calls self funded buyers proxy buyers for the individuals. I love that. Um, and and these are the people that have sticker shock. Half the people in the United States do not have sticker shock when it comes to medical services. People on Medicare, Medicaid, VA, Indian Health Service, they don't care what it costs because they're not paying the bill.
Right.
The people who have sticker shock are the people who have high deductibles, or they're paying their own money, or a self-funded company paying money on behalf of one of their employees. So these are the people that are in the room: stop loss carriers, there are think tanks there are legislators there, and physicians, obviously. So the Free Market Medical Association is that gathering where buyers and sellers can talk to each other directly and more clearly define what is a mutually beneficial exchange without all the fog machines in the room that the typical intermediaries like to bring along so that they can skim off of the transaction.
Mm.
Uh, so that is a very vibrant, growing organization. We've had Ron Paul and Steve Forbes keynote those large gatherings. Everyone should everyone should keep their eye on that organization as it grows. The price gougers in the United States will have more and more difficult time carrying on business as usual.
Amazing. Where do you find the minutes in a day to do that as well? uh, Switching gears, because we're winding down here, I have to ask you, Doc, tell me about propofol, because I had two colonoscopies and they gave me propofol both times, and both times I was angry when they woke me up because I was having the best dream of my life.
There you go.
What is the story with that stuff? What does it do to you physiologically? Why did Michael Jackson want it so bad?
Propofol is one of the um, inventions that change things. When I first started my anesthesia training, because I'm old, the drugs available to us to induce anesthesia were pretty limited. We had sodium pentothal, which typically left patients feeling hungover
Mm,
and oftentimes very nauseated. There's another drug called etomidate, which had issues with it, but like sodium pentothal, left people hungover and even more nauseated than sodium pentothal.
mm,
When propofol arrived, it basically works in the same way, but it comes on very very quickly. Its effect is very fast, but then it wears off very quickly.
mm,
So it comes and goes, and it's not there, and that's because it is not fat soluble. So it doesn't stay in your body and just kind of leak out of you over time, making you feel hungover. It comes in and it's gone, and
mm,
it's powerful and it's wonderful, and it made outpatient surgery more of a reality because nausea was not the issue that it had been prior to propofol.
mm.
Propofol actually has an anti-nausea effect. So it's a great drug. It revolutionized really the practice of anesthesia and made so much more available outpatient surgical procedures than prior to its coming along.
Huh. And so it was really a game changer.
Oh yeah.
But am I hearing though that depending upon the surgery, if it's a long surgery, many hours, it might not be the drug, right? Because it's
No, it's the price of propofol now that it's generic is so reasonable that it's actually cheaper to administer propofol. When I've crunched the numbers, it's cheaper to administer propofol in a continuous infusion than it is to deliver these expensive inhaled anesthetics
huh.
like sevoflurane that we use. And sevoflurane's a great drug, but when you compare it, when you really crunch the numbers and look at it, propofol has the edge on being less expensive. It wasn't that way in the beginning. In the beginning, it was almost cost prohibitive to provide a propofol infusion as a complete intravenous anesthetic, but that's not the case anymore.
Huh. So would you say you use it as much as anything else?
Yeah, well, we use propofol on adults exclusively to induce anesthesia, and then many times we'll switch over to an inhaled anesthetic like one called sevoflurane.
Mm-hmm.
That's also a great invention and a great improvement over what we had in the past. On really long cases, oftentimes we'll induce with propofol, switch to an inhaled drug, and then for the last hour or hour and a half, switch back and finish the procedure with propofol so that the patient wakes up very, very clear headed.
Mm. So are you still regularly practicing anesthesiology?
Oh
Is
yeah,
that is
yeah.
that
I've
is that
got
the bulk of what you do?
Yeah, I've got full time anesthesia practice, and I have great anesthesia partners who are very forgiving when I need to do things like this.
Wonderful. So if folks want to find you, how do they reach you?
So the Surgery Center of Oklahoma is on Facebook and on Instagram and on Twitter and on
Surgery Center of Oklahoma.com.
surgerycenterok.com.
OK.com.
Yeah, we're on LinkedIn. The Free Market Medical Association is on LinkedIn and Facebook and Twitter. I don't know if it's on Instagram or not. I think it is. Um, and there are a lot of videos that I've made, video blogs, all of which are available at the Surgery Center's website, surgerycenterok.com, that talk about some of the challenges we've had and encountered, that talk about some of the stinky things in the industry that we've discovered. But most of what you'll find at Free Market Medical Association and Surgery Center of Oklahoma is extremely upbeat good news,
Mm,
because this our efforts are not really so much at trashing the price gougers and the thieves. Our efforts are devoted to continuing to build and expand a very healthy, competitive market economy, and make sure that this medical industry obeys the same discipline that every other industry in the United States has to endure. So it's a very good news, upbeat sort of vibe that you get in my facility and on our website and at Free Market Medical Association.
well, it is good news. When I first was indoctrinated into the whole concept of healthcare's big lie and believing that there's nothing that you can do about the cost of healthcare. When that myth was dispelled, and it didn't happen all at once, as you can imagine, and I encourage everyone that's new to this to approach it with a healthy dose of skepticism.
Oh
Don't
yeah,
take don't take anything at face value, but as you journey and as you dive in and you realize what can be done, and I would encourage everyone to go out to that website, surgerycenterok.com, and take a look. It's mind blowing because you have the anatomy of a human body with with little dots on it, and you could zoom in on any area that might be ailing you if you have a scheduled procedure, and you actually can see the all-in bundled cost of surgery for that procedure. So if it's a knee replacement, boom, there's the price. And by the way, one of the things that was surprising to me is, and you correct me if I'm wrong, doctor, but if someone does elect to go to your facility and have a knee replacement surgery, in the unlikely event that there is a complication that causes or requires a second surgery, is that a covered event?
it varies patient to patient and individual to individual, but the easy answer to that is yes.
So it's
So
it's kind of like a warranty that's
it
built in.
it is, and we can't guarantee everything, because not everything that happens that's wrong is completely our fault.
Mm.
We had a patient have an open procedure on their ankle about 2 months ago, and 3 days after surgery decided to go swimming in a farm pond. Well, he has a horrendous infection,
Oh God.
but that's not our fault. So
Right.
now
Right.
we are not charging him, the surgeon and on the anesthesia team, we are not charging him. But on the facility side, surgery center, I'm charging cost of supplies, and that's
Right.
it. So
Yeah.
he's in an unfortunate situation. Our pledge to patients is we would not attempt to profit from their misfortune.
Hmm.
And so that is our overlying philosophy with, what what happens when something goes wrong.
Yeah, no, that's very admirable. And I guess so. I guess that would be on a facility by facility basis, but by and large, the benefit to having a bundled price is a warranty is typically part of the deal. Whereas if you're in a traditional healthcare environment, you'll be responsible for your fair share of the expense depending upon how your plan is designed, and that could be significant. But what I'll tell you is having been a partner in a self-funded plan and gone through open enrollment, I've had the pleasure of seeing how grateful an employee can be when transitioning from a fully insured plan, Blue Cross Blue Shield in this case, to a plan that really is a high performance custom health plan where, as long as she accepted guidance from the plan and went to where the quality was highest, her out-of-pocket cost was zero.
Yep.
So you have an employee that's transitioning from an environment where, and we know that, nationally, statistically, all the studies show that most people have left less than $600 saved for a rainy day, and yet we strap them with these high deductible health plans, the average cost of which is now over $1,700. It's just what we're doing is we're putting healthcare out of their reach. And so to have this woman in tears during open enrollment recounting her story of how grateful she is that this plan changed and that now she actually has money in her pocket that otherwise would have gone to the insurance carrier. As much as I love the idea of helping organizations save millions, it's those stories that really, make my heart sing, because you really feel like you're making a difference in the lives of people. And Dr. Keith, you're doing that every day. So,
One of the organizations we deal with is a municipality. It's Oklahoma County, the largest county in the state of Oklahoma, and they do what all self-funded organizations with us do. They waive all out of pocket, so the patient pays nothing if they make the smart decision. And in December, without fail, there's almost always a patient who will tell us Junior is having their tonsils out and we're having Christmas. Until this plan came along, we were going to have to choose because they have no out of pocket. And so it is transforming to the lives of the employees, as you've said. I mean, it's transforming for them to not be bankrupted for the care that they need, and the barriers are otherwise so high with no more money in the bank than most people have. They don't even get the care.
yeah. Yeah, one other thing I want to touch on before we close today, and we had a conversation, and I was describing to you that we're in a plan that is a fully insured plan through my wife, who's a speech language pathologist. She does God's work. She works with learning disabled, learning challenged kids with autism every day, improving their lives. And so our healthcare comes through her employer. And you said you got to get off that plan.
Oh yeah.
So how does one make the transition if you're in a fully insured plan, and the majority of us, it's about an even split, a little bit more than half the country get their coverage through their employer, through private insurance. How can you go about making that switch and do so seamlessly and affordably? How does that happen?
So do an internet search for cost sharing ministries, and as an individual, approach your employer and say, "Listen, I don't want your benefits anymore. Will you gross up my paycheck because I'm not going to be costing you anything for benefits?" And most employers will be happy to do that. Look at Christian Healthcare Ministries, Samaritan Ministries, Medishare, Sedera. They're those organizations basically work as cooperatives where members pay other members' bills, and there is not some army of $5,000 suits on the other end smoking cigars and laughing at you every time you pay your premium. So I belong to to Sedera, but I recommend all of those organizations. They're all wonderful. They will be much more affordable than any sort of deduction that's coming out of your paycheck, and you'll have complete control over what doctors you see, what facilities you patronize, um, and they will incentivize you. If you are making the right decision, they will incentivize you. So I would encourage everyone to get off of those kind of plans, because the worst part of it is not the cost. The worst part of it is they decide what you can and cannot buy, and you end up being a self-pay patient anyway.
Yeah. And I think the direct primary care movement, to your point earlier, is something that is starting to get some legs in this country. It's starting to get some traction. And I'm really excited about the implications of that, because I believe that, Alan Marshall passed, and he was a champion for, really fighting for the rights of the underdog and people, something that I'm very passionate about. And he was the first guy that I heard make the statement, we're in a healthcare bubble. And I believe that we are in a healthcare bubble. But as you said, your story and stories like yours and the DPC movement, those are feel-good stories. It's good news.
It is.
Because I think we're on the path to getting our lives back, getting our health back, getting control back. And it really just takes a little bit of, poking and prodding, screw your thinking cap on, and these solutions are out there. It's just a matter of grabbing that brass ring and going for it.
Yeah, DPC is the most disruptive part of this free market transparency movement in the United States, in my opinion, because once the hospital employed primary care doctors walk away and establish their own $100 a month unlimited access kind of just concierge practice, once that happens, they will no longer be beholden to these behemoth hospital systems to which they were required previously to refer. So it's extremely disruptive, and it's just it's a wonderful disruption that's happening in the marketplace now. I think all self-funded employers should seriously consider, like I do. I pay 100% of the membership to a DPC practice for all of my employees. I think all self-funded employers ought to seriously consider that.
Yeah, no doubt. And we're going to do an episode strictly focusing on DPC, because we could talk for hours about that. But in a nutshell, you're going to a doctor that has a fraction of the caseload of a regular primary care physician. You're going to spend less time waiting around in their waiting room. They're going to spend 4 times as long visiting with you, getting to know you. And then when you need care, they're actually going to be your quarterback, and they're going to assist you in navigating and guiding you to high quality healthcare. So it's an amazing model that I don't even think we've seen the beginning yet. We're at the infancy.
I agree.
Dr. Keith, man, we learned a lot. I really appreciate you joining us today and sharing your wisdom with our audience. I can't thank you enough for visiting with us, and hope to have you back again one day.
I enjoyed it. Thanks for having me.
Oh, thank you so much. And until next time, folks, peace and love. Take care.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show, and join us on the next episode.